companies.
I'm Jamie Murray with Helios Specialty Healthcare. Today we're going to have an open and honest conversation with two subspecialty trained urologists, Dr. Etai Goldenberg, Dr. Majdee Islam. Today we'll be talking about men's health issues, including vasectomies and reversals, Peyronie's disease, and ED. So with that, let's go ahead and get started. Go ahead and introduce yourself, gentlemen. Dr. Goldenberg.
Hi, Etai Goldenberg. I'm one of the partners at Urology St. Louis, which is powered by Helios. I've been there for 12 plus years now, which is crazy. I did my training at WashU in St. Louis, and I did a fellowship in New York where I specialized in men's health issues. And that's what I do every day, take care of men with erectile dysfunction, fertility issues, and Peyronie's disease. Maj?
Yeah, so my name's Majdee Islam. I am also a urologist at Helios Specialty Healthcare, and I've been there for almost 4 years now. And I did my training at University of Colorado in Denver, and then I did a fellowship in men's health as well, where we specialize or get trained in men's health-related things, specifically things like low testosterone, erectile dysfunction, Peyronie's disease, and microsurgery, doing things like vasectomies and vasectomy reversals. So Dr. Goldenberg and I did similar training. I did my fellowship out at UCLA in California and then moved back home to St. Louis, where we are practicing men's health medicine together.
Yeah, we brought the two coasts together, right?
There you go.
Great. Thanks for joining us tonight. So the first thing we'd like to talk about is a lot of men have questions about vasectomies and what is involved with a vasectomy, how difficult a procedure it is, and what happens with that procedure. So let's go ahead and tell us about what happens with a vasectomy.
So a vasectomy is a permanent form of male sterilization. What we do is we stop sperm moving through the reproductive tract. So the vas, or the vas deferens, is the tube that takes sperm from the testicle out into the ejaculate. And what we do is we stop that flow of sperm. We're not removing the testicles. We are not castrating them. We're not changing the ability to ejaculate. What we're doing is we're just making it that once the procedure's done and you're fixed up, you're fixed, and you don't have any sperm in the ejaculate. Sexual function should be the same. And so it's a procedure that's designed for men that have kids and don't want any more. So I really stress to patients when they come in to talk to me about the procedure that it's a permanent form of sterilization. There are vasectomy reversals. I think we're talking about those soon. But the idea is that when you come in for vasectomy, at least in your mind, I recommend that you think that this is you're done, and you and your partner have talked about it and have decided we're finished. That said, I think that's the biggest challenge in a vasectomy is making sure that you understand it's permanent. The procedure itself is, for the most part, a breeze. You come in the day of the procedure. I usually do them on Fridays. The whole thing takes about 20 to 30 minutes max. And then you can drive yourself home. A lot of my patients really like to have a driver so they can just sit back and relax. And more or less sit on the couch for the weekend afterwards. Get some frozen peas and some jockstrap and kind of just chill out. We get the busiest for vasectomies during March Madness. March Madness is a perfect time to kind of sit on your bottom and watch your basketball team either win or lose. And that's it. After 2-3 days, you can get back to light activity. I tell my patients to stay away from heavy lifting, sports, or sex for a week, and then you should be able to get back to what you want to. Most of my patients say by 2 weeks they feel completely normal. There are some risks, like any procedure. There is a small risk of infection. There's a small risk of bleeding. There's a small risk that doesn't work. So we test patients 3 months after the procedure. The hope is that there's no sperm at that point. You have to keep using protection until you have a semen analysis that shows that there's no sperm. Sometimes it takes a little while for it to clear. But for the most part, once there's no sperm on one semen test, you're in the clear, you're good to be sterile. There's about a 1 per 1,000 or 2,000 patients that unfortunately things grow back together and there's a pregnancy. And then there's about a 1 in 10,000 chance of having long-term pain.
And one of the nice things that we do is we use the fellow sperm testing system so that people can create that sample in the privacy of their own home.
Yeah, so what happens is when you come in for your vasectomy, the day of the procedure, you buy a kit. It's from this fellow company. Fellow does a great job. And so what we do is they buy the kit, they register that I have my vasectomy today, and on their phone they get some confetti and says, congratulations. And then starting about 12 weeks after the procedure, they get nonstop emails from Fellow saying, all right, send in your kit, send in your kit. And so at your privacy of your home, you ejaculate in a cup, then you take the specimen to UPS, and then within 3 to 5 business days, you get an answer. Either, hopefully, it's a, hey, no sperm, good to go. Congratulations. If there are sperm, what's really nice about this fellow company is they will then tell you, go ejaculate some more, and then send another kit in. They will ship you a kit to your house for free. And they will do that until you are cleared.
Yeah, and a couple, important things also, just like Dr. Goldenberg said, is with a vasectomy, it's about as minimally invasive as it gets. There's, depending on who you are in terms of being in terms of the urologist, either 2 tiny openings about 5 millimeters in size or 1 tiny opening in the middle of the scrotum. And so we're really not doing a whole lot to you to get to doing the procedure itself. And on top of that, more often than not, you're awake, you're in our office. I play some music in the office when I'm doing it. I talk to you about sports, about the weather, about your life, and 15, 20 minutes later, you're on your way out. So it's pretty much as non-invasive as it gets. Also, on top of that, it's from a male standpoint, the easiest way to keep yourself from being able to have another pregnancy. It's much more invasive on a female side to have sterilization if you're going to, have your tubes tied or something of that nature. So something that is important to note is it's much easier for you as the man to have the sterilization procedure done as opposed to your partner or your spouse, just because it's an abdominal procedure. Birth control, as I'm sure many of men's spouses will tell them, it's not a whole lot of fun to be on. It can cause a lot of issues with hormonal imbalances and things of that nature. And so from a vasectomy standpoint, for 15, 20 minutes and then a week of taking it easy, it's a pretty easy decision for most guys to be able to have some stress-free time with your partner for the rest of your life.
There you go.
Exactly.
And I think you and I both do a non-scalpel approach. So
yes, that's right.
The way that I was going to say is that the way we do the procedure, and I think part of it, trained in men's health, is you can find that vas deferens, that tube, so easily, and the skin is so thin in the scrotum that we can do the whole procedure with no knife. It's really just spread the skin just enough for that tube to pop right through. And it really, I don't even put a stitch in the skin. That skin heals up within 2-3 days and has a small scab on it.
Mm-hmm.
And it is a permanent procedure. However, there are very rare cases where people decide that they do want to start having children, and there's other procedures available for those people, correct?
Yeah. Life happens, right? And then things change. And so there is a possibility that a man will have a vasectomy and then choose that he and his partner want to have more kids. And there really are 2 options if that man wants to father kids using his sperm after a successful vasectomy. One is doing a retrieval of sperm, so you can get sperm from the testicle or from the epididymis, use that sperm for IVF or in vitro fertilization. That maintains the vasectomy. You can get sperm that way, but unfortunately the sperm that are used can only be used for IVF, which is more of an invasive procedure for the man's partner. So given the situation, depending on the man's issues and the female issues, sometimes that's the right choice. The other option is a vasectomy reversal. A vasectomy reversal, we kind of undo the work that we did to do a vasectomy. And with that procedure, what we do is we remove the area where the vasectomy was done, and then we kind of find that tube again, the vas deferens, and we sew it back together. Sometimes that scarring has gone back so far, we had to take the vas deferens and bring it all the way to the testicle itself. It's either a vasovasostomy or a vasoepididymostomy. The procedure is done under a microscope. Usually takes a while, so a lot of my patients will do it under anesthesia. It can be done with you awake as well. We make 2 small incisions, find the area where the channel is open. We look in a microscope to make sure we see sperm, and we bring things back together. Success rate varies. A lot of it depends on how long it's been since your vasectomy. The sooner from the time of your vasectomy, the less scar tissue has kicked in. But overall, my success rate's over 85% of my patients have sperm in the ejaculate within a year of their procedure. Really depends on how long it's been, and number one, and number two, the partner situation about pregnancy rates. Pregnancy rates about 50% of couples. Like any procedure, there's risk. It is a little bit more of a procedure than the vasectomy. There are incisions. It's a little bit more of a painful recovery than the vasectomy itself, most of my patients say. So I really tell my patients really about 2 weeks that they want to take it relatively easy. The hardest part, my patients say 3 weeks, no ejaculation after the procedure. So that's probably the biggest complaint. But after those 3 weeks, you can get back to trying again. Small risk of bleeding, small risk of infection, and possibility that we do that and it doesn't work. Like I said, 85% of the time it works and there's sperm, but there is that 15% chance where a vasectomy reversal doesn't work, and then we have to go usually with the other option of retrieving the sperm for IVF.
Yeah, and I think something after vasectomy that a lot of guys don't realize is you still have semen. So when you ejaculate, you still have fluid that's going to come out. It just doesn't have sperm in it. And so after vasectomy, we're not removing sperm. It's not that you're not going to have sperm for the rest of your life. You still have sperm that's made in the testicle essentially forever. We can always get to it. The question ends up being, how do we get to it? Is it going to be with a vasectomy reversal? Is it going to be with the testy, the sperm extraction? But the long and short of it is there's always options to achieve pregnancy, almost always, after a vasectomy. Just the question is how invasive you want to get to be able to do that, how long it's been, but also, there's a financial aspect to it that comes into play as well. And so, with making that decision, just like Dr. Goldenberg said, a lot of it has to do with not just your health, your spouse's health, your spouse's age, what makes the most sense to you in terms of procedures. Just because with an extraction, you take that sperm and have to use it for IVF, so your spouse has to go through a procedure as well. With a vasectomy reversal, you just get to have some fun after you're done. However, if it fails, then you're stuck with option number 2.
Back at square one, right.
So different things come into play with making that decision. It's a bit nuanced. There's a different answer for every couple that goes through this situation. So some definitely to have a conversation with one of us about if you get to that point.
Right. And I think also if you're in that situation, to have a conversation with your partner and having your partner see a reproductive endocrinologist to kind of understand the kind of pros and cons for her about the IVF process or trying naturally. And sometimes they'll really help us and say, oh, we found this on your partner. You guys would have to do IVF no matter what. It kind of changes the conversation where, oh, you're having regular periods and there's not a problem. We expect that if he had sperm, you'd have no problem getting pregnant.
For sure. If your partner is 25 and healthy, it's very different than having a 45-year-old partner, because the different things from a female standpoint come into play as one of many things that would come into play talking to the reproductive endocrinologist. Yeah.
45 is young, right? Because that's my
45, right, exactly.
Very. So one of the other things that we want to talk about is Peyronie's disease. I'm sure that a lot of guys see ads for it, and I know when I see an ad for some of these, ED or Peyronie's, or the information that you get is really coming from the pharmaceutical company or the manufacturer of a device or something like that. And it's difficult to get good, independent advice from specialists like yourselves. So tell us a little bit about Peyronie's disease and treatments for it, and how that's been a growing procedure recently.
Sure. So Peyronie's disease, I always like to tell guys, it's essentially some kind of deformity with your erection. So when a man has an erection, if there's curvature, if there is indentation, if there's an S shape, if there's length loss, all of the above come into play in terms of it being defined as Peyronie's disease. And so, there's commercials out there which are fantastic in terms of getting more awareness towards Peyronie's. But the long and short of it is, it's some kind of erectile deformity that a man has, that a man develops after usually some kind of micro trauma. So something happens to a man, usually during sexual activity, that causes some bending. That bending then causes inflammation in the lining of what's called the corpora, the erectile part of the penis. And then it forms, think of it like a scar. We call it a plaque. That plaque doesn't allow that area to expand as well, which then causes those issues. It can cause curvature, it can cause length loss of the penis, it can cause some discomfort for a certain amount of time after it develops, and then after a certain amount of time as well, it can progress. So the other big thing with Peyronie's is after a certain amount of time, it usually will, what's called mature. This plaque, the scar will stop growing, but that time can be up to even a year and a half or so. So once you've developed the scar tissue, in about 50% of guys, it continues to progress for a certain amount of time. Progress meaning the curvature worsens, the indentation worsens, the length loss progresses. In about 45% of guys, after around 6 months or so from injury, it stays right where it's at. And really only in about 5 or 10% of guys does it improve over that time. So, a couple misconceptions about Peyronie's is, it's only in old guys. It's only going to happen if you're older, in your 60s or 70s, and that's not the case. Actually, the average age is usually around 50 to 55 years old in terms of development. And on top of that, hey, it's something that's just going to take care of itself. If I leave it alone and continue to get erections, it'll figure itself out. And, 95% of the time, unfortunately, that's not the case. Peyronie's is also something, that I think really affects guys from a psychological, from a mental standpoint. And there's quite a bit of data behind that shows that when a guy gets Peyronie's disease, it really affects their mental well-being, not only in terms of their feelings of self-worth. Oftentimes erections really mean a lot to guys. You've had it for a long time. It means a lot to you. It's been your buddy for quite some time and put you through some good times. And so then when you have this injury, this deformity, it can really affect you not only anatomically, but also personally. A good percentage, 30 to 50% of guys with Peyronie's develop clinically diagnosed depression, and about 50% of guys in studies have shown that it can affect their intimacy. It affects their personal relationships with their partners. And so Peyronie's, it's not just a disease, an anatomic issue, but it can progress into really affecting guys' quality of life from a mental health standpoint, affect their relationships, affect the closeness that guys feel with their partners. And so it's really something that can affect a guy's entire life and make it something that's sometimes pretty devastating. And the nice thing is there's treatments for Peyronie's that Dr. Goldenberg and I do quite frequently. There's three main options that I usually tell men about. One option is just what we call penile traction therapy, stretching of the penis. You take the penis, you put it on stretch. Ideally, over time, that helps to almost, stretch the plaque, stretch the scar tissue. That's going to be the least invasive way to treat it. Frankly, that's usually going to be the least effective. Most men have a pretty minimal amount of improvement with just stretching by itself. And so if it's something that's not super bothersome, if it's something that you want to improve somewhat over time, but it's not really affecting you, that's an option. And with Peyronie's, a lot of times when we say it's affecting you, it can cause, pain like we talked about. It can make sexual activity more difficult because of the curvature and the angle with the curve or the deformity that the penis has can make it more difficult to achieve certain positions during sexual activity. It can also cause, if there's hourglass or indentations, it can cause what we call fulcrum instability. The penis can kind of flop over even though it's erect, which causes penetration to be difficult, sexual activity to be difficult. And then finally, it can cause issues with overall erectile function as well. And so if you think about that scar tissue not allowing the erectile body to expand, causing deformity, it can also cause a less rigid erection. And so then there's this chicken and egg. If you had some erectile dysfunction prior that caused a little bit of bending that caused this injury, then it can progress into the issues with the curvature, more predilection to inflammation and bending, and then furthering of the scar tissue. And so all of the above can be enough to cause guys to come in for treatment, but it can be as simple as, hey, my penis is bent, it's deformed, it's not like it was before, and that could be enough for guys to seek treatment. So then the more effective, quote-unquote, treatment options include something called Xiaflex. It's an injection that's basically what's called collagenase, an enzyme that breaks down that scar, that plaque. It's called collagenase, which the scar is made of collagen. And so we inject the scar tissue essentially to break it down. This medication literally breaks down these peptide bonds and disintegrates the plaque over time. The other option is surgery. And so surgery, there's a couple options. One of them, we place sutures in the skin where the bend is and tie those sutures down to straighten the penis out. The other option is literally excising, cutting out the scar tissue, and then putting a graft in its place. There's pros and cons with all of those options. As you would imagine with an injection, it's much less invasive. It's putting a needle in the penis, which is not, a small task in and of itself for most guys. The injection usually usually takes about 10 seconds to do in the office. It is a gradual process. So it's usually 8 injections over the course of about 6 months. We call it one round of injections. And so guys come in a couple times in a week to do injections. 6 weeks later, another 2. 6 weeks later, another 2, and then another 2 at the end. And so 8 injections. About 80% of guys after the 8 injections have enough improvement to where they're satisfied. And so it's a great first option. In our AUA guidelines, it's actually the only grade B recommendation, meaning it's a high recommendation for treatment and the only non-surgical treatment. So it's a great treatment for guys that have Peyronie's disease, that is, we call it mild to moderate Peyronie's disease. If it's over 30 degrees of curvature, under 90 degrees, and it doesn't have any major complex features that are involved. With the surgeries, those come into play where either more complex patients that aren't interested in having needles placed in the penis, patients that potentially are from further away that can't make it in 8 times over the course of 6 months, or patients that just prefer to have a surgery over the injections. Surgery, more often than not, is going to take care of the curvature. However, it's more invasive, and there's some more risks that are involved, which can include length loss of the penis. It can include sometimes decrease in sensation of the penis, amongst other things. However, it's pretty darn straight pretty much right away. And so there's definitely pros and cons between the two. But the most important thing, Peyronie's is something that really affects guys pretty significantly. It causes significant decrease in quality of life. But most importantly, there's pretty easy and straightforward treatments, no pun intended, to treat the Peyronie's disease that most guys are pretty darn happy with. And it's something that we do quite regularly.
Yeah. I mean, I think in my mind, what I talk about with patients that come in is, first off, the degree of bother that they have. And so on one hand, it doesn't really matter to me how much it curves. If it's bothersome to the patient or bothersome to their partner, it's worth intervening. And so, I think that's the first thing I usually ask my patients when they come in with Peyronie's disease. It's like, is this painful for you? Is it painful for your partner? Does it affect your ability to have intercourse? If they say yes to any of those things, we move on to the next step. And usually in my practice, the next step is doing an ultrasound of the penis, which I think is what you do as well. And what's nice about an ultrasound is it gives us a lot of objective information. And so I think sometimes it's helpful, for me and the patient to say, let's take a look. And so we do this ultrasound test. It shows the blood flow to the penis. It shows the plaque, or that area of deformity in the penis, shows if that's made of calcium, or shows if it's a non-calcified plaque, which is a little more common, and then can help us really give an objective measure of how much curvature they have. And then based on all those characteristics, I can sit down with the patient and say, okay, we have this ultrasound picture, and we can put it together with what happens with you and your partner, and we'll invite the partner to have that conversation with us as well, and then make a decision based on exactly what you said. Do we do nothing? Because now you have this number, and you can say, I looked at this, and it's not so bothersome to me. We can do traction therapy. We can do Xiaflex. A lot of my patients will do Xiaflex in conjunction with traction therapy, which there's data to say that improves their outcomes. They can do surgery, either the plication surgery, the grafting surgery, or some of my patients will do a penile implant to fix their erectile dysfunction and their curvature.
And I think you make a great point with bother, because bother plays a huge factor in this. You could have somebody that comes in who has 90 degrees of curvature. It's the worst curve I've ever seen, significant length loss, but it's really not bothersome to him. He may have came in because he felt a lump. He wanted to make sure it wasn't cancer, but it has no effect on his quality of life. Of course, that guy, no reason to treat because it's not bothersome to him. You could have someone that comes in that has pretty mild 30 degrees of curvature, but he's a young guy, he's super sexually active, and this is something that's not painful, not getting in the way of sexual activity, but it's bothersome enough cosmetically to him to where it's something they want fixed. And the important part with that is, because it can progress over time, just because it's 30 degrees doesn't necessarily mean it's not bothersome enough to where it should be treated. And then again, to your point, even if somebody is single, isn't sexually active currently, that doesn't mean you shouldn't have your Peyronie's treated. And I think a lot of guys out there aren't sexually active or are single, don't have a partner, have Peyronie's disease, and potentially wait to come in until they have a partner. And I think it's important to note that, getting treated, awareness is huge. Getting treated once you realize you have it is huge. A lot of these guys are misdiagnosed with, erectile dysfunction. They're given Cialis and say, hey, go home and have a little Viagra, see how it plays out, because they go to their providers and say, hey, I've got some erection issues. And the assumption is it's erectile dysfunction. So the fact that we have these commercials where we're getting some awareness for Peyronie's is, I think, huge for getting guys into the office and getting treatment for this issue that's really become a growing problem. 1 in 10 guys has Peyronie's disease, which is significantly higher than I ever thought, 10 years ago when I first heard about 15 years ago, hopefully now. But it's something that really is, it affects guys, but it's treatable is the biggest thing.
Right, and I think I'm older than you, so when I was in training, we didn't have Xiaflex, and so when I came to practice and Xiaflex came out, I think it really is a game changer to have a available option, a FDA-approved treatment that's a medicine for this therapy, and I really think that the floodgates open with patients coming in now that there's awareness with commercials, and I think just social media and TikTok and all the things that people are getting information from. But I think that's a positive thing. There's been disease state awareness, so people know that this is something. Like you said, it's 1 in 10 men, and most commonly guys in their 50s that come in and say, "This has been a big change in my life. I want to have an intervention." And it's really nice to say, we have options for you, and that option doesn't always involve surgery. And I've been, super impressed with the outcomes that we can get from Xiaflex.
Yeah, Xiaflex is great, and surgery is a great option too. I think again, counseling is important to these guys, figuring out what makes the most sense for them, what makes the most sense in our minds, and then applying that to come up with a decision that makes sense to everyone. Most importantly, to the patients, for sure.
Yeah. Yeah, and there's no harm in coming in and getting checked out and getting diagnosed properly by a urologist.
For sure. I feel like, just to sit down and have the conversation with me or with Maj and really to finding out what's available and where you're at. And I think I have a lot of patients that choose not to have therapy and are just happy to know what's out there. And, again, I've been practiced longer than you. Some of these patients come back 5, 7, 10 years later and they say, "Hey, we talked about this a long time ago, and now I think I'm interested to talk about it again." And I think that's great. And I don't think there's not a right answer for every patient, and every situation is different. But I think that because we have practices that are so dedicated to these issues, I think we kind of understand those nuances and can explain to a patient, here's what you can get and here's what you can't get from each one of these therapies.
For sure. Yeah, it's always worth a conversation. And frankly, a lot of guys are afraid of surgery. And so the nice thing with Peyronie's disease is there's fantastic non-surgical treatments that work, data proven 80% of the time. And so I think, with Xiaflex coming into play here in the last 10 years or so, it's definitely been a game changer in Peyronie's disease treatment, for sure.
And then, kind of along those lines of, we just touched on it right there with some, ED conversation, and the advertising for ED is all over the place. If you're, really any man, that's online. And so where does that journey start with ED and, I guess the treatment of ED? When should somebody come in? Is it if it happens all the time, once in a while, or I guess, you just see people whenever they're ready, and then let's talk about what the full gamut of treatment is from, just living a healthier lifestyle all the way up to, we do implants, is kind of the final step.
You want me to start?
Please.
Yeah. Okay. So I think we were talking before about Peyronie's disease, that it is, common. It's 1 in 10 guys. Erectile dysfunction is extremely common. So the literature will say that half of men over 40 will have some degree of erectile dysfunction. So it is extremely common. And as you age, that the odds of having problems getting an erection and maintaining that erection that's satisfactory for you and for your partner is even more. And so the truth is that when you get to these men that hit their 70s, about 75% of those guys will have some form of erectile dysfunction. So extremely common, and I think that's why you see all that advertisement out there, because there's a lot of men that are suffering with issues.
And to your question, Jamie, real quick, erectile dysfunction, like Etai alluded to, it's not just not being able to have an erection. It's the erection that's satisfactory to you and your partner. So that can mean having an erection that's nice and rigid for 10 minutes and then starts to, decrease in rigidity, meaning, we call it maintenance. It can be, from not having an erection that's satisfactory, even though you're getting erections that are good enough for penetration, all the way up to just not having an erection, period. So erectile dysfunction, like Etai said, is something that's not satisfactory for you or your partner. So it doesn't necessarily mean that you don't have erections, period. A lot of these guys potentially wait to come in until they're not having erections, but really we should start, addressing erectile dysfunction as soon as it comes up, just because the literature does show erectile dysfunction oftentimes is a precursor to things like heart disease, diabetes, etc. We oftentimes see erectile dysfunction well before these other more significantly important life disease processes that come into play.
Yeah. So, erectile dysfunction can happen for many reasons. It can start in your head. You can have stress, anxiety. You could have relationship issues. And, if you're not in a place where you are, interested, that can definitely have effect on your sexual function. Something that also is really important for sex drive and desire is having the right amount of testosterone. So testosterone is the hormone made from the testicles, and testicles have two jobs. They make sperm and make testosterone. And as men age, they often will make less testosterone. And so the most common symptoms of a man that has low testosterone are decreased sex drive, decreased desire, inability to lose weight, feeling just tired, and having erection problems. And so one of the first things I'll do when a guy comes in and says, I have erectile dysfunction, is to check their testosterone level. And I think like Maj alluded to, once you kind of get that signaling going, you have to be able to get that signal kind of from your brain down to your penis. That requires some intact nerves. And so men that have any type of neuropathy, especially I see lots of men with diabetic neuropathies that have challenges getting erections. And then you have to have the right amount of blood flow. So anything that affects blood flow can affect your ability to have blood flow into the penis. So if you think of an erection, it's a vascular issue. It's blood flowing into the penis and to maintain the firmness or rigidity to have intercourse. And so if you don't have that flow of blood into the penis, you're not going to get a good erection. And so if you have poor blood flow, you'll have poor blood flow to your penis. You can also be at higher risk of poor blood flow to your heart and have a heart attack or a stroke. And like you mentioned, there's data to say that sometimes ED is the first sign of those blood flow issues. We don't treat those things, but we definitely can recognize those things and make sure that you are doing things that are important to help blood flow. Exercising, especially cardio exercise, not smoking, eating healthy, controlling your cholesterol. I'll refer a lot of patients back to their primary care doctor and say, I'll treat their erectile dysfunction, but you need to make sure that, we're not missing anything else important that can be, got to be alive to have an erection. So that's first step. So that's kind of the workup that we do. Anything else you want to add about that?
No, I think you hit the nail on the head. I think the biggest thing is making sure oftentimes we'll see guys who haven't seen a doctor for 10 years and we've seen them for the first time. They've seen a doctor, which is one of us, for the first time in 10 years for their erectile dysfunction. And so, I like to say erectile dysfunction is an effect, not a cause. Erectile dysfunction is something that happens because of something else going on, lack of blood flow, because of cholesterol issues, because of diabetes, heart disease, testosterone problems. But as men get older also, you can have someone that comes in who's a picture of health and he's 45 years old and runs marathons every year. You have a certain amount of, we call it fibrosis, scar tissue that forms in the lining of the artery of the penis that can affect erectile function that actually starts at a pretty young age. And so you can be completely healthy otherwise and still have erectile dysfunction. And so those guys are coming in and it's completely appropriate to seek treatment, even though you feel like you're completely healthy. But the important thing, though, is making sure that you're seeing a primary care physician, making sure you're not missing one of these other things that can pretty significantly improve your erectile function just by taking care of it. If you're someone that's diabetic, you get on diabetes medications, it can help erectile dysfunction. If you've got high cholesterol, it can help erectile function. If you don't exercise a whole lot, getting blood flow to the entire body can help out. It's multifactorial is what we always like to say. There's multiple reasons more often than not that someone has erectile dysfunction. Usually we're not saying, hey, this is what I just found out is causing your erectile dysfunction. Let's put this Band-Aid on it and then we're going to figure it all out. That's almost never the case. And so making sure that you're doing all of the above to ensure that you're not only treating your erectile dysfunction, but you're going to stick around for a long time on this earth as well.
And then kind of the next step is then pharmaceuticals, and there's a lot of...
Yeah, so first step is usually lifestyle modification is the best that you can do. Exercise, not smoking, controlling your diet, going on medication that can help any of those underlying problems that we find, like diabetes or high cholesterol. But once you've done that, the next step is usually so checking your testosterone. If the testosterone is low, usually we'll give treatment to raise the testosterone to the normal range. But if you've done all those things, then the next step is usually pills. The most common thing people know of are Viagra and Cialis. There's other ones that are on the market. The way those pills work is they improve how much blood flows into and stays in the penis with stimulation. So I have patients asking me all the time, it's like, if I take a Viagra, am I going to walk around with an erection all the time? And the idea is that that's not how the medicine works. The medicine works by stopping the cyclic GMP pathway, which is a complicated way of saying when you are stimulated, it keeps the stimulation there longer. And so when a man is engaged, takes a pill like that, it has to get into their system. So Cialis takes about an hour or two. Viagra usually about an hour, works better on an empty stomach. And you take the medicine. If it's in your bloodstream and then you start engaging in sexual activity, you should get a stronger erection and maintain your erection better than if that medicine was not in your bloodstream. Side effects are usually some flushing and some headache sometimes, and some men, especially with Cialis, get low back pain. And those are really the first line of therapy. And I have a lot of men that are do really well with these pills. The thing is, I think that they're pretty low risk. You can't take them together with nitrates, which are certain heart medicines. But otherwise, they're well tolerated and do well. And nowadays, most primary care doctors are pretty comfortable writing for these medications. And I will say our practice is more that most men have tried Viagra, Cialis, and some of the other alternatives, either with their primary care doctor or online pharmacies and things like that, and are coming to us because they've tried those things and have failed. And so I think that's where we see lots of patients that say, I tried those medicines and they haven't been working. What else can I do? That said, I'm happy to see whoever. And I think if you're having issues with your erections and you're not happy, I think it's worth an appointment with a specialist and kind of see what's there. But I think our kind of normal patient or index patient is usually someone that's seen their primary care doctor, they've tried Viagra and Cialis, and they come in to see us and say, hey, I've tried these things and what else is available? Agree?
Yeah, my favorite line to tell my patients is, hey, you've got erectile dysfunction. You've tried whatever you've tried. We can always get you an erection that's rigid enough that lasts as long as you want to. The question is how aggressive and invasive you want to get. Everybody knows about Cialis and Viagra for the most part, and there's other more invasive options that are more effective, and it really just depends on if that's something that makes sense to you, if you're comfortable with it. We can always get you to the point where you're going to have erections that are rigid enough, last as long as you want to, and then we're going to take this journey together to figure out what makes the most sense for you, kind of step by step. And our pathway usually is to start with the more conservative options, start with things like pills. If you've already taken them, great. There's combinations that we can do to try to induce a little bit more stimulation, a bit more nitric oxide. And if that doesn't, or blood flow, sorry, and if that doesn't do what we want it to do, then we start talking about these other options and see what makes the most sense to you. There are some guys that are afraid of needles. There are some guys that don't love the idea of the lack of spontaneity. There's some guys that want something that's going to be more consistent. They don't have to worry about, putting something in the freezer or worry about having this device that they carry around. We'll talk about those options in just a second. And so, the counseling, talking to each patient about what the options are. You can have somebody that looks the exact same on paper, and the appropriate or the treatment that you come up with can be very different for those two people just based on their comfort levels. And so, those options, include a vacuum erection device. There's injections we can do. There's a small little pill that we can put into the P channel all the way up to a surgery. And sorry, you were about to talk about that. I think I don't want to steal your thunder.
You're good. No, go for it. But I will say, like you said, there's not a right answer for every patient and definitely for every couple. And I think that part of the process, and you called it a journey, which I think is great, is that this is something that we can find a solution. And there's always an option, and the idea is what you want to do and how you want to get there. And I think the more information you have about what options are available, the more you can make that decision on what you want to do. And so what's available, there's, again, I do have patients that come in and they say, I've tried all these pills, but I'm taking my Viagra right with dinner and a glass of wine. And, I'll tell those patients, if that's probably not the best way to take that medicine. It works better on an empty stomach. It works better without alcohol. And sometimes we'll combine some of the other medicines together to give them that option. Then option of a vacuum erection device is a tube that goes over the penis. It pulls blood into the penis, and then you put a small ring on the base to maintain the erection. Vacuum erection device should work with almost any man. The idea is that you have to be able to tolerate it and want to use the device before sexual activity, and then the ring that you put on the penis in order to maintain the erection often causes some discomfort and changes ejaculation and sensation. There's the possibility of doing injections. Injections are medicines that are injected right directly into the penis that are more potent than the Viagra, and also you don't take it through your mouth and so it doesn't go to your whole body. The idea is you can direct the medicine right into the penis and to give an erection. There's varying doses and concentrations and formulas. I usually use something called trimix, which is 3 medicines mixed together to give back the most punch. But the idea is that you give the injection, usually within 5 to 10 minutes, you get an erection, and the erection, you can titrate the dose, but I tell my patients that goal of 30 minutes to an hour of an erection afterwards. It's potent stuff, so there is a possibility of getting a prolonged erection. So I test my patients in the office the first time to make sure they're comfortable with the injection process and make sure that we're comfortable with the doses they're going to get so they don't have a problem at home. But yeah, if you get an erection that lasts for 4 hours, that's an emergency. That happens extremely rarely for my patient population, I think because we do a good job teaching them in the office, and I know you do the same. There's an option of wave therapy, which are the shock waves or pulse waves that go to the penis. Shockwave therapy is a non-FDA approved option. It's the small pulse waves that go to the penis and cause new blood vessels to form inside the penis to allow for better erections. The literature is good, and it's approved in Europe, currently not approved in the United States. We do offer it at Urology St. Louis because there is some benefit to it. I think it's a nice option for men that really don't want to move on to more invasive therapies, and there's really no risk. The risk of a medical problem or a complication from that injection, from that wave therapy, is extremely low or really unheard of. But there is risk to your time and to your wallet because it's not covered by the FDA. It's a cash pay procedure. And then the other option is a penile implant. Now, a penile implant is the highest satisfactory of all the options. 90 to 95% of patients that undergo a penile implant are satisfied and happy they did it, and 90 to 95% of their partners are happy that they had a penile implant. That said, it's surgery. It's usually an outpatient surgery. Our patients come in, they have the procedure done and go home the same day. Some patients do stay in a hospital overnight. The way a penile implant works, it's a small incision in order to put a device inside the erectile body. And what we do is we replace those blood vessels that weren't working to deliver flow to get an erection and replace those with cylinders that are controlled by a pump. That pump sits in the scrotum. You pump in order to get an erection, and then there's a release button to let the erection go away. And the nice thing about a penile implant is once it's in and it's functional, it's in your body. It's spontaneous. It's always with you. And it's easy to use. The average device lasts around 10 years or so. If a device fails, it's another surgery to replace it. There is risk of infection or bleeding or injury, and you have to be healthy enough to have an anesthesia that's required for the surgery. But in my practice, patients are extremely happy with the penile implant. I tend to use it as, I call it a last resort because they've at least considered or tried and failed all the other options. But at least I think that resort is an excellent option, and most of my patients are really satisfied.
No, I think it's a great summary. And I think, my spiel, I guess, that I give patients, is very similar. I usually try to go through all the options from the get-go so guys know exactly what the options are, what they're getting themselves into. The vacuum erection device, I like to tell guys that it's a good option. It works. It should work for everybody. It's cumbersome, not the most comfortable thing in the world. Really, realistically, it's about 50 to 70% effective just because the rings can get loose. If it's too tight, it's uncomfortable. Sensation decreases. I do have, a handful of patients that have used it regularly for years, decades even, and are quite happy with it. And so it's a very reasonable option. The injections, I think are a fantastic option. They are, just about 85 to 90% effective. The needle, the thought of the needle, I'll tell guys, is a little bit worse than the actual needle itself. The poke, most of my guys say, is pretty minimal, if anything. Some guys tell me they don't feel it at all. And so the thought, the apprehension of having a needle in your penis oftentimes is much, much worse than the actual injection. And it works pretty darn well. There's a ton of different concentrations, like Etai said, to where there's a pretty good chance we're going to find something that works for you. And it can be pretty spontaneous. Once you figure out how much you need, it's as simple as taking the medication out of the fridge, injecting yourself, and then within about 5 or 10 minutes, you've got this erection that is going to work just fine for you. I have plenty of patients that travel on airplanes with it, and so it's something that you stick in your checked bag. TSA doesn't give you too much of a hard time, usually if you carry it on, but checking it has no issues, just making sure you take a little cooler with you. And so, I think the injections are a great option. I mentioned briefly the we call it Muse, the suppository in the penis. I don't think I've prescribed it twice in the last couple of years, mainly because it's not as effective as the injections. And it's super pricey. There's also quite a bit of burning that comes along with putting it in the P channel. So I tell guys, hey, if you're going to do this, it's not as effective. And if you're okay with doing something like that, you're going to be just fine with a needle that's going to be more effective, not as pricey. So I
think the idea of the needle is scarier than the needle 100%, itself. And 100%. I think that's why, and I think you do the same, is I have patients come in for the first time to learn to do the injection. And oftentimes I'll inject them myself. And they're like, that's it? Like, I was worried so much about that. And I think it's, for a lot of my patients, they are, it's kind of a myth-busting experience that they're like, okay, I can do that. I do have some patients that their partner does the injection. I think it's, like you said, once you know the dose and you know what works for you, I have lots and lots of patients that are very satisfied. It's reproducible. It's enjoyable. Very few complaints about, the challenge of doing the injection, even though I think most patients come in worried about the ability to do it, or do pretty well injecting themselves at home. And, they tend to be pretty happy. And once they do it, it's a non-surgical way to get, where they want to go. That said, if a patient is doing injections and they either don't like doing it, they don't like the process, or that, in some men, that doesn't work. If you think about what's going on, if you have issues with blood flow to a degree that despite the injections, you're not able to get a good erection, penile implant is, I think, a really good option for them.
Yeah, and I think, just like we mentioned earlier, each option, just like you mentioned, each option is a bit more invasive, a bit more aggressive, but a bit more effective. Vacuum erection device, so injection is going to work, let's say 80 to 90% of the time. The implant, once it's in there, it's going to work every single time. The exact same erection, no matter what. Within about 30 seconds, when you pump it up, 30 seconds to a minute, it's going to be the same every time. Now, it's the most aggressive option, the most invasive. You have a surgery. Surgery is pretty straightforward. It takes about an hour and a half or so, and then you head home afterwards. And there's a recovery period. But once you've done the recovery period, once you've had the education on how to pump it up, it's, I've said game changer a couple times during this interview, but it's a game changer. It can be life-changing for these guys. And, it doesn't come without risk, though. The big thing with any kind of surgery, it's invasive. There's risk involved. The risk of infection is there. It's low. It's about 2 to 4%, but it can be pretty devastating, just because if you have an infection, we have to surgically remove the implant, give you antibiotics, and then we wait a few months to put the implant back in. So my point in saying that is it's a big decision to make. It doesn't come without risk, and you can't go backwards once you've had the implant. So
it's the only option that's permanent.
Right. We always counsel patients on the fact that once you have the implant, you can't go backwards, but we prefer that you do all the other conservative options, or at least think about them, because there's no burning of bridges, if you will, if you do any of the above before doing the implant. I have plenty of guys that come into the office saying, I have zero interest in putting a needle in my penis. The vacuum erection device sounds terrible. The Cialis Viagra didn't work for me, and I'm going to get this implant. And frankly, I don't have a huge problem with that, as long as we've had this conversation of, here's your options. I want to make sure you understand that this is permanent. And I've had guys that have gone through that and been extremely happy. But the biggest thing is knowing what you're getting yourself into with the penile implant. And that being said, a significant majority of men that have the penile implant are ecstatic. They go from not being able to have a sex life, not being able to be intimate with their partners, to then being able to be intimate at the drop of a hat. It can be pretty life-changing for not just men, but their partners as well. And, we say spouses, partners, it can be used for any kind of sexual activity in general. So that can be, oral sexual activity, manual sexual activity, vaginal intercourse, anal intercourse, all of the above. So any kind of partner, whether it's yourself or somebody else, can be involved with a penile implant.
I think the other thing about an implant is that it does fix the erectile dysfunction. Also, if you have a patient that has Peyronie's disease or some type of deformity in the penis, you can usually correct that at the time of the implant as well. So, when I have patients that come in with erectile dysfunction and severe Peyronie's disease or some type of penile deformity, I think it's reassuring to them that we can hopefully fix everything in one fell swoop, so they can have a functional penis after the procedure.
Yeah, it's something where kind of the same thing. There's a little bit more awareness of erectile dysfunction. Most guys understand and know what erectile dysfunction is, but we do have patients that'll come in that had no idea that there were other options other than just popping some Cialis from the gas station or something of that nature. So again, like we mentioned earlier, the important thing is coming in to have a conversation with your, maybe not even your urologist, just your primary care physician, some kind of physician that can give you at least a little bit of a pathway, if not point you in the right direction about what your options are.
Yeah. And I also think it's important that, you two are, if not the top 2 implant surgeons in St. Louis, 2 of the top surgeons, and you're not like so quick to give somebody the implant. It's like, we're going to go through this pathway. We're going to try all the things that are less invasive that, could work for you before we end up, with this, permanent fix. But, you can fix everybody. It's just a matter of what path they end up on.
Yeah, I'll tell my patients, honestly, I want you to talk me into doing the implant. You're going to have to really tell me that this is something you want to do. I won't talk anybody into doing an implant because it's a big decision, and I don't want to be the person that comes in and tells somebody to have an implant and then come back and tell me, hey, this is not what you said it was going to be or anything like that. I want you to come to that conclusion yourself. Of course, I'm going to give you the information and let you know about what, in my mind, makes the most sense for you. But I want you as the patient to tell me, yes, this is the route that I want to go. I'm going to do the implant, and these are the reasons why. So I think, again, counseling is important, but making sure that you as a patient understand that this is a big decision, and I won't. I tell guys, I'm a surgeon. I love doing surgery. I will make sure that you do the conservative things first, or at least have a long, hard conversation with yourself or your partner about doing the more conservative things before we think about putting an implant in.
Yeah, I'm the same way. I don't want my patients ever to come back to me and say, you didn't tell me that X, Y, and Z. I really try to give them all the options that are currently available. Now, we're sitting here in 2026. I'm hoping in 2036 that we could have this podcast again, and there'll be new options available and things that aren't available. Right now, I think we've covered all the things that are out there, and patients can try, and hopefully kind of opens our eyes to kind of what's available. In terms of a penile implant, I think that exactly what you said, you don't really talk someone into it. But I think if a patient has tried and failed or really is uninterested in the other options, it really is a great option for them. And I think there are lots of misconceptions out there about how invasive it is and how risky it is. And I will say, despite there being risk in having to undergo general anesthesia and having an infection risk, I think the things that we both do in our practice, having patients take antibiotics before the surgery, giving IV antibiotics during the surgery, sending them home with antibiotics, the devices now are coated in antibiotics, so when the device is implanted, the risk of infection is extremely lower than it used to be. And I think that is some misconceptions out there that, it's a high-risk procedure, and I would think that you and I would call it a routine procedure that we do on a regular basis. And for the most part, patients are really happy. And I think as long as they understand there is a potential for these bad things to happen, but they do happen pretty rarely. And, I think the patients tend to be very satisfied. I think the patients that come back with penile implant to my office afterwards, 95% would say that they would do it again. And really, I think it is a game, like you said, a game changer. It is a life-changing operation, especially for my patients that had their erectile dysfunction because of something that suddenly happened to them. Most commonly, they had prostate surgery, their prostate removed, they had cancer, they're cancer survivors, or they had their bladder removed and then no longer have the nerves that go down to the penis to allow them to get the erection. So especially these men that go from having normal erections, then having cancer, and then not having any erections at all, I will say those patients really say that this is a life-changing experience to get their erections back.
Mm-hmm.
Yeah, that's a great way to wrap it up. And you both are doing webinars coming up in the near future. And then we also have some of your past webinars on our YouTube page that people can watch. With the upcoming webinars, they can listen in, watch the presentation, ask their own questions. We always do question and answer at the end. And really that's it. And then I think the big thing is that people, if they have questions about any of these issues, it's always easy to come into our office. The first visit is painless conversation most of the time, and we have solutions for a lot of their issues. So, thank you both for doing this. I really appreciate it, and we'll probably be doing another one in the near future.
Thanks for setting it up.
Yeah.
Thanks everyone that tuned in.
Yeah, thanks a lot.